Hello, everyone. Welcome. I see folks joining us, coming in, seeing lots of lovely, familiar faces that make me feel so happy to see. I see Lauren Thompson and Andrea Cook are like the first people popping up on my screen. So this is actually like super fun to see folks. Wonderful. We'll be getting started shortly, just giving everyone a chance to get settled. Awesome. Thanks. All the numbers are still climbing up. Well, this is great. I am going to take this moment to get started. We're at about 12:02 and we have a jam-packed hour. So welcome everyone. If you happen to have unmuted yourself, please mute yourself again, just so that we don't pick up your audio. Today, welcome to our MRCT Center 2023 Health Literacy Month webinar on amplifying participant voices. We're going to be talking with three wonderful panelists about their experience, both crafting respectful, inclusive, and understandable patient materials, receiving such materials, maybe not receiving such materials at times. I'm Sylvia Baydorf-Cassis. I'm a program director here at the MRCT Center who has had the great privilege of working in the health literacy space the last 6 years. And I'm joined by Maureen Kashuba, Marty Carney, and Marilyn Knott, who are three wonderful professionals and advocates, and wear many different hats and play many different roles in this space of amplifying participant voices. We have a bio book. In order to do justice to their amazing experiences, we have a bio book about all of our panelists that will be placed in the chat and also will be available after the webinar, so you'll be able to read up on them and send that information out to others. But I'm really glad you could join us today to hear a little bit more about this work that these folks have been doing and that I get to sort of moderate and give some perspectives on. So, usual disclaimer is that these are our opinions and not necessarily intended to represent Brigham and Women's Hospital, Harvard, Merck and Company, LLC, or any other entity. We are, as the MRCT Center, funded by a number of different voluntary contributions from a number of different sponsors and sources, but regardless of who funds us, we are committed to autonomy in our research and transparency in our relationships. So we retain at the MRCT Center all final responsibility and control of our results and deliverables. None of the speakers that I'm aware of have personal conflicts of interest relevant to this presentation. So welcome. I've said welcome twice now, but I want to highlight something kind of unique about this meeting and the meetings that I've been trying to run over the summer and to now and moving forward, hopefully. We are in a meeting. Usually when you go into a Zoom webinar, you kind of go in solo, you don't see who else is there, and you're kind of in this little, very controlled environment. Really nice for the speakers and the panelists because there's no wild cards. We kind of, everybody's quiet and we can't really have interaction, but that is not the point of what I want to do with these sessions that we run. You are all part of a community of people who care about health literacy, you care about amplifying participant voices in research, you care about being allies for those that are underrepresented, marginalized, underengaged, disenfranchised. We are here to try to lend some perspectives on doing this work as allies in the space. So take a look, flip through the participant list, see who's here, see your colleague from across the country who might be joining and it's the morning for them and it's nighttime for you or whatever it is. And also just use the private messaging too if you want and say hi to someone. Maybe there's someone on this meeting that you've been dying to chat with at some point and now you're here together and it's like you're in an auditorium. Say hi. And just, a shout out to them. So with that said, as I mentioned, since we're on a meeting, please keep yourself muted so that we don't have the extra noise, but that doesn't mean that you can't interact. Like I said, use the chat for interacting with each other and submit questions to us via the Q&A function so that we are able, as me, the moderator, and the panelists, be able to keep track of what questions and comments are coming in. We have closed captioning available today via a real-time transcriptionist. You can activate that on your own side on Zoom by clicking the closed caption button at the bottom of your screen, and you'll be able to have that real-time transcription. That transcription will also be available along with the recording and the slides and the bio book and any other resources in a few days after this webinar. Okay, so welcome again. I'm going to go over an intro to the MRCT Center and health literacy, and then we'll have our panelist presentations from Marilyn Knott, Marnie Carney, and Maureen Kashuba, and we will definitely have time for discussion and Q&A. So, in case you aren't familiar with the MRCT Center, I know many of you are. We're a research and policy center based out of Boston and Cambridge, Massachusetts, that's focused on addressing the conduct, oversight, ethics, and regulatory environment of clinical trials. We always want to improve the integrity, safety, and rigor of global clinical trials through our work. That's our vision. And we do so by engaging diverse stakeholders from across the ecosystem to define emerging issues in global clinical trials, and then to create and implement ethical, actionable, and practical solutions. And you can see from that list that there's nonprofits, industry, patients and patient organizations, academia, government, and journal editors that are part of our community. And of course, we also have others that work in more contracting spaces, et cetera. We have a really nice representation of many of these groups today in our panel. A patient advocate who also worked as an audiologist for several years in the academic space, in the research space, working with pediatric populations. We have someone who works with all kinds of patients and patient advocates at Brigham and Women's Hospital. We have someone in industry from Merck who's going to talk about their experience. And so what is health literacy? Like, what is the definition so we can just ground ourselves before we get into the amplification of patient voices to improve health literacy? Well, Healthy People 2030 kind of turned the original definition, which only focused on sort of the individual user, the personal health literacy, and expanded it to have two prongs to that definition. Personal health literacy, which really does focus on the degree to which individual people have the ability to find, understand, and use information to make those health-related decisions and research-related decisions for themselves and others. Organizational health literacy, though, is a huge piece of this, right? This is the degree to which organizations, the places we work, the environments we move within, equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. And so today, because we can't raise the entire health literacy of the entire world, we're focused on the places where we, in our organizations, can start to move the needle in terms of integrating individual feedback, patient feedback, so that we can understand what does equity look like to our patient and participant populations, and how can we best craft information, resources, and the like, so that we can equitably allow them to access our services, access our research studies, and be able to be empowered to have some control over their health and research decision-making. So the MRCT Center, since about 2019, I came on board in 2018 actually, came out with a few resources in the health literacy space, focused on that organizational piece. Health Literacy and Clinical Research website really gives tools to sponsors, investigators, IRBs, on how to implement or will recognize and implement health literacy deficits and where to make improvements in their processes. We've developed a health literacy IRB training that can be accessed online. And I highlight here the checklist because, similar to what I said earlier, these practical solutions that the IRB focuses, that the MRCT Center focuses on, is really a huge goal of our work, right? Not only will we elucidate the issues, but we will also perhaps give you a tool to be able to put into action in your own role. So we have this IRB checklist that accompanies the IRB health literacy training. And then the MRCT Center Clinical Research Glossary, well, that is this really lovely partnership between sort of having something patient-facing. We have this patient-facing, participant-facing glossary we're developing that is also designed to be used by industry to use plain language definitions and content in their patient-facing materials so that they're able to speak the same language as participants. So we have this goal of harmonization moving forward. And we have a new partnership earlier this year with CDISC, the Clinical Data Interchange Standards Consortium, which will make this glossary and plain language definitions a global standard for clinical research in 2024. And so there's more about that in the future too. And a lot of these links are being put into the chat by Kristen. So you'll be able to access that, and of course in the slides, and you get them later. So with that said, we focused on health literacy best practices across under this umbrella of numeracy, clear design, plain language, interactive techniques, cultural considerations. But today we're really predominantly focused on this area of like usability testing, this talking to people, getting feedback, integrating patient and participant feedback into our pipelines to better understand their needs and meet those needs. So with that said, I'm going to turn over the mic to Marilyn Knott, who's going to give us some of her perspectives as a patient advocate and someone who's also worked in the area for a while. And Marilyn, you just feel free to let me know when to advance the slide so you feel comfortable with how I'm moving through this.
Sylvia, you're so funny. You always remember that there's something silent in my name, and it's the E. And all times was fault, and it's not your fault that nobody can remember that.
Not. That's right. I always want to say Marilyn, no, but that is my Frenchy side. But there we go.
Well, there you go. That's what they would say in my husband's town of Biddeford. No.
Yes. Well, I'll pass it on to you, Marilyn. Feel free to go ahead.
Well, we are all patients, every one of us. I've had the opportunity to be on the clinician and researcher end as well. But now that I'm retired, I do look much more from the patient viewpoint. My interest in health literacy started many years ago when I went to a lecture at a convention for audiologists and speech pathologists, and the lecture was about health literacy, which at the time was a new concept for me. And the speaker included videos in which people were interviewed about their own medications. And never will I forget this video clip of a woman who looked entirely cognitively intact being interviewed about the bottle of pills she held in her hand. The interviewer asked, "What does discontinue mean?" Because it said to discontinue after 10 days. She said, "I don't have a clue." So it really got me thinking about the way I explain things to deaf and hard of hearing children and their parents, and to substitute smaller words for bigger words whenever possible. I enjoyed teaching graduate students that when they talk to families, to try to talk no faster and no fancier than they do, which is a pretty good rule, but sometimes you need to talk even less fancier than they do if they're under stress, and that's even harder to listen. Now, when I retired and the focus of my existence became Parkinson's disease instead of deaf and hard of hearing children, I was fortunate to hook up with the Parkinson's Foundation and receive some training in patient advocacy that led me to get some very cool requests for fun things to do, like talking to groups of scientists and students about living with Parkinson's disease, especially scientists who would be working on a drug for Parkinson's disease, but didn't know what it was they were working toward. And it was just astonishing to me how little some of the scientists knew about the everyday existence of someone with Parkinson's disease. And I found this to be a very important link in the chain. In Parkinson's disease, the participants in studies are overloaded with white, non-Hispanic males. There are more males than females with Parkinson's disease, but there are too few participants with other ethnicities. And it's a constant problem for us, but must be addressed because the era of precision medicine is fast approaching, and treatments need to be tailored more to genetic background than they are now. Put it on the next slide, please. A few years ago, my brother-in-law stayed with us for quite some time while he was undergoing CAR-T clinical trials for lymphoma in town, and he was from out of town. So he lived with us for several months. And I would talk with him when he came home from an appointment for his chemo or radiation, and especially when he had a contact with one of his physicians, and ask him about the communication aspect, what happened. Was he satisfied? Did he understand what the doctor was saying? I was already involved in some MRCT work, and I was trying to learn the health literacy aspect from the ground level. And he was very helpful to me. He said he used to tell the doctor, "Put yourself in my shoes. Tell me what I need to know. Show me a picture. Make me say it back to you, make sure I've got it right. And tell me again tomorrow." So another thing that often comes up is that the patient should be asked what is important to them as a potential study participation is being discussed. One patient may be very concerned with finding out ultimately how they did on the study and whether or not they would ever find out after the study is over. Even though that's not the usual goal of research, the clinical improvement or clinical status, for many patients, it is important to know what we now call individual return of research results. Another patient participant might be concerned about confidentiality. Perhaps he's not out yet at work as having a condition undergoing study. Perhaps he has Parkinson's and his wife's family is from rural Kenya, where they believe that you've done something evil if the spirit has inhabited you to give you this disease. And they don't know yet. Above all, I think we like to be listened to when we offer a way that we have learned about the study or the condition and want to share it with others, or when we come up with a suggestion to improve some aspect of the study in which we are participating. We'd like to be able to understand it well enough to be able to explain it to our family when we get home, maybe even pronounce the drug we might be taking. Next slide. Now, advocacy is not a complaint fest. It's not a conquest. It can even be the expression of gratitude, which will encourage the researcher to do the same thing more. This was a clinical encounter, but when I got cataracts, I noticed that the handouts had been printed out in a large font that I could easily read. And none of the other handouts from this agency were ever printed out in a large font. And I mentioned to the ophthalmologist that I was so grateful that I could read these easily. And she was extraordinarily pleased and said she would pass that on to the powers that be, because it took her a lot of work to get them to print out this way from the desk, terminals, reception desks when you leave from your appointment. Next slide, please. But then once I was participating in a phase 3 clinical trial, and we had to record our status every 30 minutes, the form used to do it was utterly impossible. If you're going to do it every 30 minutes, you have to carry it around with you all day. And, with something to make the X on. And I was making a terrible job of it because the rows were hard to track vertically and horizontally, and the paper became absolutely mangled. So I made my own form, which worked out better, and I passed it along to the local investigator. I don't know if anything ever happened to it, but I want to show you here, show and tell. An intermediary step was when I realized the first form didn't work, I carried around a little notebook, and here's an example of a piece of paper where I would write on it every 30 minutes and then transfer it to the form. So this goes to show how participants should try out real world, try out in the real world any forms or survey materials that are going to be used before the study protocol is complete. That goes for surveys also. Are they going to get the information that you're truly asking? Okay, next, please. So there I am, showing my great willingness to try out anything in the real world. No, this is for a gait lab study. Thought you'd enjoy the comic relief. I really only wore it for a couple of hours. Okay, well, I'll stop there. I know we'll have time for discussion later.
Thank you, Marilyn. I really appreciate that. Well, Marty Carney, you're up next. I'm going to pass the mic on to you. Welcome.
I'm so delighted to be here. I will start back because we all have individual stories. In 1964, when I was a junior in high school, my father was a practicing physician and was diagnosed with Alzheimer's disease. He got on a research program in Albany, and surprisingly, his doctor requested that I come to one of the meetings. At that particular time, I had no idea what that would really mean. And for me to be there was very interesting. Move forward to 1988. By the way, we did have to do a lot of research with him. And at that time, hyperbaric chambers and there were really no medications. It came back, and I'll share that with you later, to really encompass a great deal of my life. But in 1988, I was diagnosed with breast cancer, and I got involved to be an advocate in that arena for the what I call the pink ribbon era. Did a lot of that work and dealt with probably over 2,000 women over that period of time and ran a support group. Meanwhile, in 1997, Dana-Farber Cancer Institute started to bring the patient and family voice into healthcare, and I was fortunate enough to be part of the first patient and family advisory council in the country, where we really started making a difference in patient care. Then in 2005, during that work, we had an opportunity where we were supposed to go, it was patient safety, and we were supposed to go and meet with other patients to find out if they knew what to do if they had an urgent situation in their oncology environment. Sounded like good fun, and okay. Well, the researcher gave us the questions that we were supposed to ask. There were 4 of us. And when we looked at the questions, none of us would have answered any of them. We revamped the entire process. Well, little did I know that in 2005, 2014, Pete Corey would come up with the opportunity to bring the patient voice in research. And through Brigham and Women's Hospital, I was fortunate enough to be on the first large 10-site, multi-site grant for falls prevention. And I was able to I was put in the position of the lead advocate, where we began to realize that we needed multiple voices and multiple experiences. And from there on, here I am. So when I was reflecting back on it, I couldn't believe that had all come together, but it has. So I would like to tell you, how do we do all of this and why? So if we could go to the next slide, please. This is what we started out with a review process. This is health literacy related. We started out receiving the documents from the staff. Then first thing we ever do is the readability, because what you have given us to look at, whatever position it's in, we have to get it down to the right readability level. The Joint Commission says 6th grade level. Most of the times these come in high school or above. And this was even before we had the emphasis that we've learned so well on people with limited English proficiency, things that have to be translated and so forth. So we reviewed the health literacy PFAC that we have once we get the document, and then we communicate that back with the research staff to see what they think. Once we all meet together, we redo it, and then we go back again. This started out to work really well, but what we have found over time is that doing it via email and not doing it in person, which currently we don't do a lot in person, as we all know, it's really a lot easier to just Zoom away. We have found that the Zoom process works really well in allowing everyone to be on the same page, no pun intended, at the same time, because we can do it that way. So when you do this, I always say, and you've gotten some good ideas already from Marilyn, and you'll be getting some from Maureen, but my comment always is, tell us what you want to do. Tell us what you have to say. And together, we will tell you to say this so that all participants can understand it. Marilyn's ideas are wonderful, and I have what they call my Marty Carneyisms, is you need to have bifocals. I think I should have been an optometrist. You need to wear hearing aids so that you get both perspectives. You can see and you can hear and you can understand. In addition to that, this all needs to be done with the patient and family-centered care principles of treating one another with dignity and respect, information sharing with transparency, and then shared decision-making with participation and collaboration. These are key elements of patient and family-centered care, but also in relationships. And I find that I use this quite frequently in my regular life. Because this is an iterative process, we need to include both parties. And I think that's by, once we've all sort of reviewed the material, when you come to a final consensus, it's nice to have both parties involved so that you're making it. By doing this, remember that we as patients aren't familiar with your medical jargon. And when you're doing research, I was pretty familiar with the medical stuff by this point, but when I was doing research, I knew nothing about AIMS. I knew nothing about all of that. And I wasn't really excited about the data. It didn't really mean anything to me. So we need to make sure that when we're doing this, everybody is on the same page and has full understanding of what's going on. It really is best for both parties. And it also ensures that the information that is spoken to people is done in the same language, because otherwise we can have misinformation that also leads to lack of trust and lack of compliance and lack of full understanding to be able to share it within the community. So in addition to that, we currently have apps and wearables that are coming into the world. And by doing that, you understand that we have multiple generations that are being treated in healthcare. And the young kids, this is great. But people like myself, I'm not that familiar, nor do I really trust it at times. So we need to make sure that the messaging goes, that it meets the needs of all participants at all levels. And then you can have a consensus on doing this. Meanwhile, what we find is if you bring the patient voice in and do this work with patients who have the lived experience, you will get a much better result. Addition, I want to bring up that just sometimes this work is done. It is not done under a normal volunteer situation, but they do allow for some type of gift cards or appreciation for focus groups to make sure that that is valued. Next slide, please. Okay, well, how are we going to build this partnership? All right, I've given you a little background on that, but all patient materials need to be vetted at every single level. We started with, on a research program, a logo to glean the interest and for recruitment. We also used it on our letterheads just to make sure that when you got information through the mail, you get a lot of junk mail. We don't want our information to go in the trash. So some type of a logo can work out, or whatever you want to use in that environment. But I'll tell you, coming to a consensus on that in 3 of my major research grants took not 2, not 4, but probably 6 to 10 iterations before everybody was happy. And that's the very important thing, to make sure that people understand what that is going out, and it also keeps them in line. Many of the trial sites have had websites. Again, if you're doing a website, you want to do what is going to be important to the participants. And then based on that, why wouldn't you have the input of your research advisors, who are not only part of, but also represent the community that you're trying to meet? So you need to know your audience. You need to use these advisors as your teachers. Because of that, you're able to work with their lived experience that Marilyn talked about, and we are able to do bi-directional learning and understanding so that it will come out. Another thing that is happening now and is very helpful in health literacy is the stories and the narratives that you get. Presenting to PCORI in, I think, 2019, I was able to say that an N is a number, but an N with a narrative is a compelling story. That information validates the research work and gives more credibility to what you're doing. Again, it's through the health literacy aspect that everybody can understand what is being done. Additionally, we've recently brought in, we can be intimidated when we come into this world, and we're working with any healthcare professional, particularly in the research world. Patients have a PhD, and when we were coming up with this, that's a personal history of their disease and their lived experience, and they also know what matters to them. But when we came up with that, we realized that it put patients in a more comfortable situation. It allowed the communications to flow more freely, because they too had something behind, some initials behind their name. They too were an important part of the process. If we don't understand, how can we trust? How can we participate? And how can we comply? Remember, when you are talking with them, to forget that you are not talking to or for them, but you are talking with them, because together we need that bi-directional conversation to make sure that your research goals and aims are met, that we could do it and understand it and participate equally. Next slide, please. I think I want to talk a little bit now about, okay, where do we get these advisors from? How do we do it? How do we find them? We have found that doing it at the Brigham, we do it through our patient experience office, and we use patient surveys. Also, our patient relations office has both the positive and the negative complaints that they receive. We use them to find out who is able to speak out well and what we might be able to change. And also, most importantly, I think in research, when you're doing research, you usually have clinical staff involved, and they are usually directly involved with their patients so that they have an opportunity to bring those patients and their experiences and their voices forward. That is helpful. The one thing that I will say to all of us when we're looking for advisors to help us do this health literacy is it's difficult if you put a sign up and advertise that you want people, because I call it the come on down group. You spend a lot of time on vetting. So I think it's important that we use references if we can. Everybody's concerned about vetting and how do you make sure you've got the right person? Well, it's not too difficult. We call and discuss the expectations and the commitment. Then we ask them to share their stories or their experience in healthcare or research. It's pretty simple. What went well, what did not, and how would you change it? You get a pretty good idea then of what they're bringing to the table from their experiences that you can use in the work that you're doing, and making sure that the information that is going out meets the individual needs as well as the group needs. And also their personal experiences. One of our best advisors used to run American Airlines customer service for the Eastern Seaboard. You could imagine his experiences in that of dealing with people. So that makes a big difference with what everybody brings to the table. Sometimes, depending upon your environment, the hospital process, including occupational health and so forth, can be a little time consuming, but we have to meet those regulations, and people have to be badged and trained. So whatever it is that you need to do, we need to work together to make sure that you can get these people properly in place. I think PFAC, or Patient and Family Advisory Council, training programs, as well as actually training programs working with your research partners, make a big difference. It offers opportunities for us to learn from one another right away. And in addition to that, when you're recruiting people, they know other people in your communities as well. So I think if you can do that, it will really make a big difference in your having a truly viable working program that works for both research and also works for the community itself. I would like to remind you that once in a while, we are not regular advisors, and sometimes we have the opportunity for a little bit of a gift card. Focus groups are one of the best ways, if you want to get something done quickly, to bring people in for an hour, show them what you want, and work through. And particularly, again, on the apps, we have sometimes gotten so involved in conversations with the research group about how the apps should read and how that they should work, that we either extend or go beyond. So again, I use that as a benchmark for how well it makes, what difference it makes. I'm going to let you go now and go on to other information, because I want you to absorb this and come back. I don't want to do it to and for you. I want to do it with you. So thank you.
Thank you, Marty. So now we've had a patient experience. We've had the experience of someone as a patient who also runs these patient groups. And now we're going to pass it along to Maureen Kashuba, who's going to talk about her experience at Merck and how she's been getting this kind of feedback.
Thanks, Sylvia. I'm thrilled to be here, especially with such wonderful panelists. Really is such an honor to be here. And I'm happy to sort of give our perspective on how our team within Merck is trying to engage the patient and the public in the materials that we're preparing. So if you want to go to the next slide. We take within our plain language summaries team, which is one of the responsibilities that I have within MRC is managing the plain language summaries program, as well as our internal health literate glossary, which is a resource for internal authors to use in developing patient and public facing materials. It's intended to make it a little easier to prepare those materials by giving options for ways to describe complex clinical and medical information in an easier to understand way. We also believe it helps to build consistency. In developing plain language summaries, we take a universal precautions approach because we want to ensure that our communication is clear. And we know that making health communication understandable and actionable is both an art and a science, but it's not perfect. Actually, creating plain language summaries is an honor, and it is so rewarding, but it is also incredibly difficult. And you don't know that until you've actually tried doing it, because many people think they're very good at it, and I can speak from personal experience, until you start doing it and realize it really is a challenge. And you need to be really thoughtful. It requires an expertise in plain language, in design, and cultural awareness. If you want to click one more time, Sylvia, I think there's another. We often talk about reading level, and that's sort of the gold standard. It has to be at a 6th to 8th grade reading level, but there's really so much more, because a sentence could be at a 6th to 8th grade reading level and make absolutely no sense. So we have to also think about reading ease, using short sentences. Patients and participants will often hear complex diagnoses or health conditions or procedures in their regular healthcare encounters. So if we're talking about those, we should describe them, don't avoid them. But by using those terms, it might raise the reading level, but if we use an explanation or a description that's simple and straightforward, then that sort of addresses that advanced and elevated reading level. We also, of course, focus on formatting, putting white space, bulleted text, bolded text, as Marilyn spoke to, materials that are really actually usable for the people that need them. Those are all really important. The other piece is asking for feedback, which I think is why we're all here today, about amplifying the patient's voice. So asking for feedback is incredibly important, and finding ways to do that, because we know the gold standard is to go to patients or patient panels and ask them. That's not always possible, unfortunately, with the new implementation of the EU clinical trial regulations. The timelines for turning around these documents is very, very tight. And while we want to always ask patients what they think, sometimes we don't have that luxury. So we, within our organization, have tried to find workarounds, ways to help supplement that review when we can't go directly to the patient. The other thing I tell my team all the time, and something I try to take very to heart, is we take feedback very seriously. What people say, what they don't say, if they just say, I don't like it, we take that really seriously, but we try not to take it personally, because as I said, this is challenging work, and you can be a little disheartened when you've written your heart out and then you get all this track changes back and be disappointed. But really the feedback, every time you take that in, it makes you a better writer. We believe it ends up leading to better summaries and better communication overall. So next slide. And one of the ways we try to find ways to get that patient's perspective is we actually have two approaches. One is a layperson review of documents, and the other is through cultural competency workshops. So cultural competency focuses on providing effective, equitable, understandable, respective quality care and services. It's care that's responsive to people's beliefs, their language, their lived experience, their culture. And we know that when patients go to a healthcare encounter, their understanding of what's expected is often very different from the healthcare providers. So we're always trying to be mindful of that when we prepare health communications. And one of the pieces that our team really focuses on is cultural humility, recognizing that our individual perspectives represent our experiences and are not necessarily reflective of the experiences and perspective of others. And the only way to get the perspectives of others is to ask for feedback. So for plain language summaries, we use a process for layperson reviews. We are an organization of patients, caregivers, of family members, of culture, of community members. And so we ask for volunteers within our organization to read our plain language summaries and let us know how those summaries read. Are they clear? Do they communicate information in a way that's understandable? Do they inform? Do they tell too much, or do they make the reader automatically ask questions? And we get really phenomenal feedback from that. we learn so much from it. We redesign our template, we redesign the way we present information, and then we go back and say, here's a few more options. What do you think of these? So over time, it helps, we believe, to improve the way we write, the way we communicate, and the way these summaries will be understood. The other element that we use for this type of review and feedback is called cultural competency workshops. Sylvia, if you want to go to the next slide. This was actually designed to help review our internal glossary, which has over 1,200 terms in it. And we knew it was medically and legally appropriate and reviewed and all that was fine, but we didn't have that lens of cultural competency. So it was in the height of the pandemic, there really wasn't a lot of opportunity for taking this externally, but what we had was this untapped resource of internal employees. We're very fortunate in our organization to have employee business resource groups, which represent different cultures and communities within the organization. So we reached out to those groups and asked if they would see if they could get volunteers who could come and review our definitions for the glossary. We also asked for volunteers from our internal nurse network. We wanted to know how the definitions, concepts, and descriptions aligned with people's lived experiences. We wanted to ensure that the definitions were inclusive, they were culturally representative and culturally appropriate, and make sure that we were really clearly communicating information. The feedback was phenomenal. We've had 6 or 7 so far. We learned that our initial definition for jaundice was not reflective of how you would describe jaundice in a person of color. There are definitions about mental health descriptions that we knew it needed tweaks and refinements, and so we got wonderful feedback about that. This was all company volunteers. Nobody, everybody sort of did this above and beyond. And it allowed for open discussion, both cultural, professional and personal cultural insights. So within the breakout sessions in these individual workshops, people were sharing their real lived experiences. So, hearing from colleagues about what it was like to be 9 years old and explain medical information to their parents at a doctor's office because their parents didn't speak English. That really opens our eyes to the differences that patients and the public can encounter with their healthcare experiences. The real huge takeaway for us, honestly, was how happy people were to be involved. They were thrilled to be there. They felt honored and respected and valued to be a part of this work. They were proud to work in an organization that prioritized this type of information. And most of all, we asked them to come over lunch, and 100% of them said they would come back. So we knew that we knew we were making a difference. We knew we were having an impact, that people were willing to give lunch for the second time. But it really actually helped us understand that this is such important work, and it's a step you shouldn't skip. And even if you don't have the funding or you don't have the ability to take things externally, you've got resources in your communities, in your organizations, and you can utilize those resources to help improve the materials you create. Thanks, Sylvia.
That was great.
Thank you. I know I was on mute and then I was like, no, what am I saying? Additional. So thank you now to Marty, Marilyn, Maureen, my 3 M's. Good. So now I just want to show you a couple of additional resources that the MRCT Center has put together. I also see that there's some resources being put in the chat, so go check those out as well from others who are participating. We've tried our best at the MRCT Center to really, we have been centering patient and participant resources. We've been putting it now in a more public place on our website and really trying to highlight more of the work that we've been doing. So you can check out this URL here, and I'll just highlight 2 toolkits very quickly, and then we'll move to questions around including young people in research. We've had amazing work led by our team and Lisa Koppelman here at the MRCT Center that really talks about how you integrate pediatric young person feedback into the research process and get their feedback to ensure that you are creating clinical trials that really are accessible and understandable and meaningful to young people. And we also have amazing work that's being led by Willianne de Cormier-Plosky, who has been working on accessibility by design and really thinking a lot more about all of the barriers that are facing people in trying to get into clinical trials and trying to accessing research. And this also gives just more perspectives and more guidance and tools to help navigate that. We do have our annual meeting coming. I'll end with that after. So just keep in mind that on December 13th to 14th, we'll have our annual meeting. But I'm going to stop sharing for a second and highlight now a few questions. I have some questions myself, but a few came up in the chat actually. And so I do want to highlight just quickly. So videos. Marilyn, Maureen, Marty, are you seeing video brochures being used for recruitment, for consent, for helping participants with adherence, etc.? And are they, there's sort of multi-pronged. So are you seeing these videos happening? Are folks doing that? So Marita asked about that. And then Gary Moran was also asking about whether there's ever the inclusion then of American Sign Language by native deaf persons involved in that as well. So if you wouldn't mind just sharing a little bit about whether or not you've had any experience with doing that, or any perspectives you might be able to lend. I'll put it to you first, Marty, and then we'll see if others want to jump in.
You did.
Sorry about that. We have not had that opportunity yet. I think that should be coming through, but we've been focusing on it particularly at the Brigham, but not through videos. And I think it's a good way to start. I'm starting my 2024 wish list, and I think maybe we can put that on there, because that is a way that people get to see a real live person, not just reading about it, but talking about it and experiencing it. Do either one of you have any experiences, Marilyn?
Yes, I have participated in a study in which the protocol was explained using a video, and it was excellent. But it had closed captions. In other words, you could ask for the captions to be put on, but I believe that videos of that nature should be open caption. Just have the videos show on whether the person asks for it or not, because probably half the people who need it would actually ask for it and get it from the start of the video.
We don't know what we don't know.
There you go.
That's a universal precautions approach, I think that Maureen was getting at too. Maureen, did you want to add anything about that?
Yeah, I don't have any experience directly with it. I know there have been some discussions in industry. We're always trying to be mindful of not being promotional. And so that is the lens that we try to think about from a video perspective. From a personal perspective, though, I think so many people learn better from video. I think it's just the way of the world now, from YouTube and all of the other electronics that particularly younger generations maybe are accessing. So I definitely think there's value in pursuing it.
Well, and so for the three of you, I mean, so we're all allies in this space, right? Trying to do this work of elevating voices that may not necessarily have the chance to be at the table and share their perspectives. So, you know, you've shared a lot about what you do, but what are some of the, what's like a major takeaway that ensures that your process is inclusive and that you get representative feedback? Are there any special tips, you know, of your Martyisms? I know, Marty, but are there any special tips that you would want to share with our audience today, our attendees today?
I guess go ahead. Go
I
ahead,
just
Mary.
want to mention a fun thing that happened to me. I was in the hospital, not for my Parkinson's, but for my spine. And during the hospital stay, a resident came into the room to mention a study and asked me if I'd like to participate. And he explained it to me, and I had a chance to ask questions. The next day, a different resident came in and asked if I would like to participate in the same study. He was not aware that it had already happened to me. Well, the two encounters were quite different. One, the individual was very clear in explanation, and I understood beautifully what he was saying from the verbal explanation, and less so from the written consent that was left with me. The next day, I didn't tell him. Somebody had already been there explaining it. I just thought, well, let me listen to this. And in that case, the verbal explanation was poor, and it was worse than the printed explanation, which I relied on for him. So it goes to show, I think, when it's really important, you probably need both.
I appreciate that. That's good advice right there.
I-
Anyone else? Oh, Marty, go ahead.
I'd like to add, now in this digital world, we were doing a lot on websites. And that when we started all of this, everybody was focusing on the websites. But I'm now beginning to see in the work going forward that websites are not really as helpful as doing something like a video that's available in this digital world to add to the process that you get written materials. People learn in different ways. If we can cover all of those sites, we should be able to increase our audience and our participation.
And Maureen, any?
I say the same thing all the time, is we just need to keep learning. You do the best you can, and then you learn from it and keep asking questions. And just because you did it one way one time and it seemed good, that doesn't mean you have to keep doing it that way. And maybe there's a better way to do it. So I think it's just always being open to learn more and constantly trying to improve and always asking for new feedback, to sort of give you a broader perspective of how things are understood. But I do think, the digital piece is really important. And so I look forward to seeing that evolve.
And we do have some videos that we're working on with Fuse around clinical trials and data sharing and understanding your data as a participant. So more broad general ones. Now we only have a few minutes left, but I see 2 hands up and I'm so excited that there's such brave people who want to raise their hands and actually ask a question. So Casey, I'm giving you a chance to have like a minute, and then Sarah, I want to acknowledge you and make sure you can ask a question as well. So Casey, go ahead.
Thank you so much. So I guess I would love to see like a show of hands of how many sites or PIs here have actually tried to make a video before. Like it's hard, right? Like, am I just biased in saying that? Like, it's not really intuitive to just create a video based off of a study. So it makes me wonder, like, we already know that sites and researchers are resource strained in our industry. What can sponsors do, or what can funders do to try to support them in making video content or improving that? Because I think it's all well, fine and good to say, yeah, video sounds great, but is that really going to happen? It's tough. So I'd love to see a discussion on how that can be put into action.
Ooh, well, maybe that's a topic for 2024, putting health literacy into action in videos and clinical research. So
Yeah.
Sarah, come on down.
Hi, Sylvia. Great to see you. And thanks for this awesome webinar. We have a few of our participants from our advisory board here in the room, I can see. So thank you all for joining. For our group, I work in Alzheimer's disease clinical trials at USC. We've run the A4 study, which was the first clinical trial in preclinical Alzheimer's, so people that don't have any cognitive symptoms. So it was a challenge to recruit because it was really a newly defined population. And we did some videos, although we're hearing from our board that they really want more. We had an investigator that was willing to do very informal videos, using her phone if need be. And when the end of the study came and she was presenting them this summer, she filmed a video outside the conference summarizing the results, and that was posted to the website. So I was so thrilled to see our group embracing this, but of course we'd love to do more of that. I just want to share too, we get feedback from our board that they want more information, and when they're reviewing our consent forms, the challenge is always, how do we keep these consent forms a readable length? Two of the things our group, sorry, there's a little background. Two of the things our group has implemented to help with consent. First, our sites do a welcome packet to just address all the logistical barriers and make sure that people know that transportation is provided, parking, meals, all of that. Then we also provide the consent and also a study information guide that's available online that really expands on a lot of the topics that maybe can't be covered as fully as maybe everyone would want it to be in the consent form. So all of those, of course, get IRB reviewed. The other thing our teams have tried is a group consent, so that participants can sit together with other people like them that are thinking about taking part in a study, hear other people's questions, which sites have found to be really helpful, because sometimes someone's asking a question you hadn't thought of, and sometimes it's a question that you wanted to ask but maybe didn't feel like it was a good enough question. So I just wanted to share those learnings.
Thank you, Sarah, for sharing some perspectives from the field, from your own experience. So I know we're right at the top of the hour, and I see some comments still going in, so I'm going to just let those comments still feed out, and you can see them there. And I'll just thank you for coming and remind you we have our annual meeting coming, and this is the first time that we will actually be able to have open R3, which is our regulatory meeting, and our bioethics collaborative. It's usually just sponsors invited. These are all freely available also, and also in hybrid format, so people can join, not necessarily having to travel to Boston, but learn more about the other kinds of work that we're doing in these other spaces. And so clear communications benefit everyone. So that really aligns with this universal precautions. It's Health Literacy Month. Thank you so much for joining us today to sort of have this, I guess, brief conversation. I think we could have kept on going for a while longer. And I'm so grateful for the feedback, the active chat. There's a lot that we still have to learn around accessibility, around inclusion, around amplifying voices to ensure that we are, as allies, reaching the audiences we need to reach, and bringing them to the table to share their own stories. So I'm glad you gave us a chance to tell you a little bit about our experience here today, and really look forward to future conversations in the future. So 2023, 2024, and beyond. Thank you, Marty, Marilyn, and Maureen, for taking time out of your busy schedules to share your experience and wisdom with everyone. And thank you to all of our attendees today. Really grateful. We've got folks from California, folks from over in Europe. Really appreciate that so many of you are here today. So happy Health Literacy Month. Take care, everyone.
Thank you and your team for all your hard work, Sylvie. It really was an amazing process.
Thank you,
Sylvia.
Marty. Thank you,
Hey,
Maureen.
this is Jamie Roberts from Duke. Can I just offer just one little thing?
Yes.
Sylvia, this is really more directed to you and the MRCT team. So I developed and with the help of the Duke Office of Clinical Research, run a program here called the Engagement, Recruitment, and Retention Program, which is a certificate program that takes about 6 months for our research staff to really become much more cognizant of both the lens that they use when they're approaching participants, but also how to use the tips and tricks and techniques that take us beyond just the regulations and rules of the road for recruiting people. And I just wanted you to know that we have used a significant amount of your content from in particular, the health literacy and clinical research section of your website in our content, which is also available on the Creative Commons, so that people can download it and tweak it and customize it for their own uses. So I just wanted to share that with you and just tell you how much I've been appreciative of it. You guys have a great little video on why health literacy matters, and we make every single student watch that video.
Oh my gosh, thank you so much.
So I just wanted to share that with you, because I started my career at Duke with the Clinical Trials Transformation Initiative. So I've been watching you guys in parallel to that for many, many years. And I just wanted you to know that your material makes a big difference, and we do use it here at Duke. So.
Well, it's so nice to hear. I think that's, in the spirit of what we've been talking about here, it's great that there are good resources out there, and we know we can keep doing better. We're going to keep learning, and we'll keep improving. So the health literacy website is definitely up for a refresh. We have that. Kaylee is someone, my project manager. Well, not I work with amazing project manager, Kaylee Toe, who it's on our agenda to do an update of that and refresh. And we have some new numeracy and data literacy content to add. So, we'll keep growing, and really in the accessibility space. I really appreciate that Gary was here today to share some of the feedback on the areas where it's still not hitting the mark. And so we keep learning, and we keep growing, and we have to, we appreciate people keeping on telling us where there's areas where we need to grow. That's the only way that we can do better, is to keep listening and being open, not taking it personally, and trying to just do better in the space. So thank you. Thank you for those nice words. And thank you also for keeping us, on the straight and narrow to do this right.
Well,
so I appreciate it.
We also used your return of results, the sort of a 300-page omnibus that you put out there, but we use that as the framework for writing our own, at least return of lay summary results to research participants, guidance document, and toolkit. So again, I go back to MRCT quite a bit. I bet I'm like one of your most frequent flyers on your website. So
Thanks,
anyway,
Jamie.
just wanted you guys.
That's so nice. And I don't think I've ever even had a chance to meet you, like seriously. So no, unless anyone thinks this was a plant, it was
Nope.
not. I'm 100% surprised and tickled at this endorsement. So thanks so much.
All right. Well, it was nice. Thanks so
Well,
much for
thank
this
you.
wonderful presentation.
Thank you, Jamie. And thanks to everyone for joining and for lingering for a little bit to hear those last few minutes. So wishing you all a wonderful rest of the month and into the end of 2023.
Bye-bye.
Thank you. Bye.
Thanks.